So just to summarize, talking about en bloc versus conventional resection. En bloc TURBT was superior to the conventional technique in retrieving a high quality specimen. It also showed a better safety profile without affecting the operation time and could be adopted whenever feasible. The long-term oncologic value remains to be investigated. Sequential intravesical gem-dosi versus BCG for treatment of patients with high-risk NMIBC. So the patients treated with adjuvant gem-dosi for high-risk NMIBC after TURBT had improved high-grade recurrence-free survival and less treatment discontinuation as compared to BCG. There was a substantial difference in follow-up time between the groups due to increasing use of gem-dosi since 2019. And the results from an ongoing randomized clinical trial repeated. The issue of BCG shortage is definitely there, and this kind of addresses that issue in a certain way, but the long-term results are yet to be seen. These findings do support the use of gem-dosi in high-risk NMIBC, but we do need more prospective studies for this. Oncological outcomes of short-term intensive chemoresection with mitomycin in NMIBC. So this study reported that only half of the patients treated with chemoresection needed TURBT. However, it also introduced the risk of treating patients who do not have neoplasia of any kind. It was associated with few clinically significant side effects, however, not very well taken, and larger studies are needed. Radical cystectomy versus TMT, which was extensively discussed right now for MIBC. So it is an oncologically equivalent alternative to radical cystectomy, which needs more level 1 evidence definitely, but patient selection remains the key. Patients need to be counseled extremely detailed, and a salvage cystectomy along with a lifelong follow-up needs to be explained in detail. Standard versus extended lymph node dissection at time of RC. So we know we have more yield, might get a higher pathological end stage, but there is no significant disease-free survival or overall survival benefit to these patients in extended templates. However, it might have a greater morbidity, higher perioperative mortality is also noted. Radical cystectomy with intracorporeal urinary diversion versus open radical cystectomy. So the complication rates and 3-year oncological outcomes are definitely comparable. And the transfusion rates of a robot-assisted approach are definitely reduced by 50%. So it is a safer surgical option, but there is no data on ureteroenteric anastomotic strictures. The nighttime continence recovery was comparable, but however, in neobladders, it was not as well taken. Robotic surgery comes with its higher costs, and that issue will always be there. Primary chemoablation of low-grade upper urothelial carcinoma using UGN-101. So this study shows that this installation, their protocol of 6 weeks, is effective for primary chemoablation. This drug, however, is not available. Their analysis says it is a durable response that they've seen. But ureteric stenosis is a significant adverse effect, and it might require a RNU. So that's a major issue here. More robust data is required, preferably multicentric, to generalize the results, but it is still an experimental therapy, nothing more at the present moment. Radical dose radiation therapy in node-positive non-metastatic breast bladder cancer. So is it an effective alternative to RC? So it is offered to patient group with poor survival already, and those who are able should receive some form of radical treatment. And as a part of TMT, it might be a valid option in select patients, but needs a well-discussed multimodality approach. With the known morbidities of radical cystectomy, it can be offered as an initial thing where the patient might eventually progress to say a salvage RC. So this study was retrospective without randomization, and a larger data is needed. Thank you.